Infections due to Pseudomonas. The Pseudomonads are a heterogeneous group of gram-negative bacteria that have in common an inability to ferment lactose. The pathogenicity of most Pseudomonads is based on opportunism. Pseudomonas aeruginosa, the major pathogen of the group, is a significant cause of infections in hospitalized patients and in patients with cystic fibrosis. Thus, most conditions predisposing to P. aeruginosa infections have involved host compromise and/or broad-spectrum antibiotic use. Ventilation and broad-spectrum antibiotic therapy probably paved the way for colonization and infection of increasing numbers of hospitalized patients by this organism. Cytotoxic chemotherapy, mechanical epidemiology. P. aeruginosae found in most moist environments. Soil, plants, vegetables, tap water, and countertops are all potential reservoirs for this microbe, as it has simple nutritional needs. The majority of P. aeruginosa infections occur in intensive care units (ICUs). The classic example is CF. Others include bronchiectasis and chronic relapsing panbronchiolitis. P. aeruginosa causes infections at almost all sites in the body, but shows a rather strong predilection for the lungs. Bacteremia crude mortality rates exceeding 50% have been reported. The organism is initially acquired from environmental sources, but patient-to-patient spread also occurs in clinics and families. Pseudomonas aeruginosa can be transmitted through various routes, primarily via contact with contaminated surfaces, equipment, or water, and sometimes through person-to-person contact. These bacteria are commonly found in moist environments like soil, water, and on plants, and can colonize various hospital settings and equipment. Chronic infection due to P. aeruginosa. In the past, the patient with P. aeruginosa bacterium classically was neutropenic or had a burn injury. Today, however, a minority of such patients have bacteremic P. aeruginosa infections. Rather, P. aeruginosa bacterium is seen most often in patients in ICUs. Occurs mainly in the lungs in the setting of structural pulmonary diseases. Among patients with P. aeruginosa bacterium, consequently, this which occur almost exclusively in markedly neutropenic patients and patients with AIDS. A sputum gram S stain showing mainly polymorphonuclear leukocytes (PMNS) in conjunction with a culture positive for P. aeruginosa. This setting suggests a diagnosis of acute P. aeruginosa pneumonia. This organism appears first or second among the causes of ventilator-associated pneumonia (VAP). This organism has also been reported to cause prosthetic valve endocarditis. Sites of prior native valve injury due to the injection of foreign material such as talc or fibers probably serve as nidus's for bacterial attachment. Fever is a common manifestation, as is pulmonary involvement due to septic emboli to the lungs. Hence, patients may also experience chest pain and hemoptysis. Involvement of the left side of the heart may lead to chest radiographs demonstrated bilateral pneumonia, often with nodular densities with or without cavities. While most disease involves the right side of the heart, left-sided, this picture is now remarkably rare. Today, the typical patient is on a ventilator, has a slowly older reports of P. aeruginosa pneumonia described patients with an acute clinical syndrome of fever. Chills, cough, and necrotizing similar lesions may occur in aspergillosis mucormycosis. Their presence suggests P. aeruginosa bacterium as the most likely diagnosis. The main manifestation is pain in the foot, sometimes with superficial cellulitis around the puncture wound and tenderness on deep palpation of the skin. Manifestations are rare in this disease, and ecthyma gangrenosum is not seen. Systemic symptoms are generally absent, and blood cultures are usually negative. Radiographs may or may not be abnormal, but the bone scan is usually positive, as are magnetic resonance imaging (MRI) studies. Embolic disease arising from endocarditis in for drug users and leading to brain abscesses has also been described. The cerebrospinal clinical entity has been much feared, and its management has been the clinical presentation of vertebral P. aeruginosa. Nodular densities are not commonly seen, however, infiltrates may go on to necrosis. Necrotizing pneumonia has also been seen in the community, for example, after inhalation of hot tub water contaminated with P. aeruginosa. The duration of symptoms for drug users with vertebral osteomyelitis due to P. aeruginosa varies from weeks to months. Fever is not uniformly present. When present, it tends to be low-grade. There may be mild tenderness at the site of involvement. Blood cultures are usually negative unless there is concomitant endocarditis. The erythrocyte sedimentation rate (ESR) is generally elevated. Vertebral osteomyelitis due to P. aeruginosa has also been reported in the elderly, in whom it originates from urinary tract infections (UTIs). The infection generally involves the lumbosacral area because of a shared venous drainage Batson's plexus between the lumbosacral spine and the pelvis. Sternoclavicular septic arthritis due to P. aeruginosa seen almost exclusively for drug users. This disease may occur with or without endocarditis, and a primary site of infection often is not found. Plain radiographs show joint or bone involvement. Treatment of these forms: the typical patient has fever, leukocytosis, and purulent sputum, and the chest radiograph shows a new infiltrate or the expansion of a pre-existing infiltrate. Chest examination generally detects rales or dullness. Of course, such findings are quite common attempted with the use of multiple antibiotics. Recent publications report attributable mortality rates of 28 to 44%, with the precise figure depending on the adequacy of treatment and the seriousness of the underlying disease. The clinical presentation of P. aeruginosa bacterium rarely differs from that of sepsis in general. The only point differentiating this entity from gram-negative sepsis of other causes may be the distinctive skin lesions ecthema gangrenosum of Pseudomonas infection. Acute pneumonia respiratory infections are the most common of all infections caused by P. aeruginosa. Pneumonia indistinguishable from other gram-negative bacterial pneumonias. The traditional accounts described a fulminant infection, progressive infiltrate, and has been colonized with P. aeruginosa for days. While some cases may progress rapidly over 48 to 72 H, they are the exceptions. Among ventilated patients in the ICU, infective endocarditis due to P. aeruginosa, a disease of IV drug users whose native valves are involved. To the heart valve, the manifestations of P. aeruginosa endocaristis resemble those of other forms of endocarditis for drug users, except that the disease is more indolent than Staphylococcus aureus endocarditis. Involvement is not rare and multivalvular disease is common. Signs of cardiac failure, systemic emboli, and local cardiac involvement with sinus of Valsalva abscesses and conduction defects. The diagnosis is based on positive blood cultures along with clinical signs of endocarditis, P. aeruginosa, an infrequent cause of bone and joint infections. However, Pseudomonas bacteria or infective endocarditis caused by the injection of contaminated illicit drugs has been documented to result in vertebral osteomyelitis and sternoclavicular joint arthritis. Osteomyelitis is more indolent than that of staphylococcal osteomyelitis. Of disease is generally successful. Pseudomonas osteosti of the foot most often follows puncture wounds through sneakers and mostly affects children. Wound, multiple joints or bones of the foot may be involved. CNS infections due to P. aeruginosa are relatively rare. Involvement of the CNS is almost always secondary to a surgical procedure or head trauma. The entity seen most often is postoperative or post-traumatic meningitis. Subdural or epidural infection occasionally results from contamination of these areas. Fluid CSF profile of P. aeruginosa meningitis is no different from that of pyogenic meningitis of any other etiology.